was asked to start this off by explaining the rationale for the new nomenclature. And see if I can get this to move. There we go. So I guess to start, I think it's important for us to understand that the nomenclature of what we used to call NASH has really been an evolving thing and actually hasn't been easy even from the very, very beginning. So even in 1980, when Jürgen Ludwig initially described steatohepatitis not in patients who did not drink any alcohol, he had a very difficult time publishing this. In fact, he tried many places, and it ended up actually in Mayo Clinic Proceedings, which is not a very high impact journal and certainly wasn't at the time, but it was very difficult even back then. So 20 years later, we had a long debate in 2002 over what would be the most appropriate nomenclature, because having a non-name for a disease just seemed counterintuitive. But even then, we could not come to a consensus over what to name the disease. So in 2020, this important publication was at the time interpreted as a suggestion of what we could potentially call the disease. And it had a lot of important attributes. So it definitely took out the non-name. It removed the stigma from alcohol, which is a problem for some patients. It provided positive diagnostic criteria, and it recognized the underlying relationship with other metabolic disorders. And this, I think, these were very important points. However, there were some important issues with this particular process and also with the resulting definition. So namely, the elimination of steatohepatitis, which is really conceptually the driving force of the disease, and importantly, the allowance of more liberal alcohol use. And this is, of course, impactful because steatohepatitis, of course, can be caused by alcohol or metabolic causes, and alcohol significantly accelerates the disease and changes the natural history. We wrote a couple of editorials calling for further discussion on this, and primarily over the concern that the process had not been a very valid, open, transparent process, and really required further discussion. There was significant concern that this would have an impact on drug and biomarker development, which has been 20 years in the making. Again, the ability to add to this emerging disease phenotypes, in addition to other impacts of stigma and the impact it could potentially have on disease awareness. So this was a multi-society effort, initially conceived of by myself and Phil Newsom, but in the end was a very robust process, and I'm going to walk you through that. So this was primarily led by AASLD and EASL. Ale was a very instrumental player, particularly in the latter half of the process. There are some key attributes to a Delphi consensus process that I think certainly Jeff Lazarus can speak the best to this, but in this particular process, we tried to follow it as closely as possible. It needs to be informed by subject matter experts. It needs to be conducted using rigorous methodology. There needs to be anonymity of voting and reporting of results, and it needs to be a transparent process. The survey rounds need to be combined with in-person discussion, and this is to facilitate consensus building and to listen to one another. This allows for the acknowledgement of diverse opinions and assures that viewpoints are considered and discussed even if they don't reach the consensus threshold. So this is our steering committee. It was a very expert committee representing people from all over the world with high levels of expertise, including some patients, and of course, endocrinology and some pediatricians as well. This was as I said, a fairly robust in the sense of covered many countries. 56 countries were represented. We ended with 264 nominees from the various, the largest pan-national societies, and we did this proportionate to the association member size. We set forth that the requirements for new nomenclature, and this is based really on the first round, survey round, that this convey the underlying driver of the disease, that it be non-stigmatizing, that it account for the role of alcohol use, and it enabled the ability to parse out other specific etiologies leading to steatosis, because of course there are many things that can lead to hepatic steatosis. And then importantly, to be able to adapt to advancements in the field by accommodating disease phenotypes. And this is, again, going to become very, very pertinent in the years to come as we learn more and more and start to be able to phenotype disease. So the overview of the process is the following. So we decided a priori that there would be a supermajority to make an official change or recommendation. In the first round, we had 35 questions or statements with about 1,000 comments that we addressed, we categorized, and then addressed them, used them to then modify the second round, which ended in 52 questions, and following almost 1,400 comments, which we again categorized and then used to reformulate the next round. In between these two, we had in-person meetings. We had a large consensus conference, which was a hybrid meeting in Chicago that was a very active working meeting that was really remarkable in the sense that everybody was completely paying attention. We had no people on their phones or computers. It was very active and very robust. This followed into round 3, which ended up with 42 questions and 800 comments. And then the very final round was preceded by a Pan Society nomenclature meeting in DC at the liver meeting in 2022. So to summarize the results with respect to factors impacting the name change, through the first Delphi round, it was very clear that people had an appetite for a change in the nomenclature and a change in the definition, which needed to include the retention of steatohepatitis and the inclusion of a separate group that was alcohol combined with NAFLD. In the second round, it was determined that an overarching term was going to be the best way to go, and that if we needed to eliminate or at least consider non-alcoholic and fatty both as stigmatizing entities. The third round then designated the overarching term to be steatotic liver disease due to the fact that 66% of people felt that fatty was also stigmatizing, and then to include the name metabolic. And from there forward, we ended with 3 acronym choices that were basically equivalent across the 3, and we decided to involve an independent subcommittee that included some from our steering committee, but also importantly, external people to help us reach the third and final decision. And then carry this forward to pediatrics for further refinement of the definition that had also been achieved and decided upon by the same committee. With respect to the role of alcohol, it is quite important. Many countries and cultures regularly drink alcohol and have it as part of their social fabric, and we'll be hearing a little bit more about this later. We wanted to balance reality without negatively impacting natural history data. We wanted to avoid the risk of slowing biomarker development, and we wanted to acknowledge the fact that those with more than moderate, and I'll put in parentheses in quotation marks, may respond differently to therapeutics. And again, this is a common exclusion for clinical trials, and this population had not been previously captured. So this is the schema that we ended with. And you'll see that MASLD was the replacement term for NAFLD, and within it, MASL and MASH. MET-ALD was a new category that was created that JP will be delving into much more deeply. And then, of course, other specific etiologies of liver disease, which we will not talk about today, that also lead to hepatic steatosis. The definition really was quite simple. It basically was defining the population that we already see and take care of anyway. There really isn't anything more about this, and we can talk about it in the Q&A, but essentially the presence of steatosis with any of these 5, or actually it's 4, but abnormal lipids could be either low HDL or high triglycerides, so it really broadly encompasses about 98% of the NAFLD population. So what have we done with respect to implementation and awareness, with respect to medical education, which has really been broadly used internationally at meetings? We've updated the up-to-date source, which in the United States is a very common resource for people in training. We've updated the new, we've written a new chapter actually in Schlesinger and Fortran, are working with the ABIM. And in publications, there's really been broad use across journals, editorials outside of our liver journals, in multiple journals, high impact journals. There's been an exponential use in publications, and the Delphi paper has gotten quite a lot of visibility. With respect to use in practice, we are very excited that recently MASLD and MASH have been incorporated into the electronic medical record in the United States through the EPIC system, which is the most commonly used electronic medical record. We've submitted ICD-10 modification to the CDC and have begun to engage with the WHO and will continue to do so. So the way I see this process, it's been a long and involved process, which many of us can attest to. I think that we fit perfectly into a Gartner plot, which many difficult problems do. But I really do think that we are now at a point where we're increasingly productive and using this to hopefully advance our understanding and of the disease and move the field forward. And so with that, I'd like to thank Phil Newsom, Jeff Lazarus, and the Delphi Steering Committee for really being instrumental in making this come to fruition, as well as the full group of Delphi correspondents, the ASLD and staff and governing board, the SLD task force, EASL leadership, and ALE leadership. And I really thank you for that. These are the societies that have endorsed, actually not quite all of them, but just to give you an idea of some of the society endorsements that we have. And with that, I'll close. Thank you for your attention.